today, so you didn't have.
What? Are you okay?
Order.
Oh my God, even.
Ordered. I call this meeting to order. Thank you, everyone. This is the Standing Committee on Health, and my name is Trevor Boudreau. I'm the MLA for Richmond and chair of this committee. Today, we will hear from Nova Scotia Health and IWK Health regarding investment in robotics. So I'd ask everyone, if you have a cell phone, please put it on silent. And I will start with introduction of committee members. So I'll ask committee members to introduce themselves for the record, stating their name and constituency, starting with MLA Smith to my left.
Hi everyone, my name is Kent Smith. I'm the MLA for the Eastern Shore.
Good afternoon, everyone. I'm Chris Palmer, MLA for Kings West, and welcome.
Good afternoon, I'm John White. I'm the MLA for Glace Bay and Dominion.
Good afternoon. I'm Danielle Barkos, MLA for Chester St. Margaret's.
Good afternoon. I'm Sue LeBlanc. I'm the MLA for Dartmouth North.
Hi, Gary Burrell, Halifax, Chebucto.
Welcome, everyone. I'm Rafa Di Costanzo, the MLA for Clayton Park West.
Hey, everybody. Brendan McGuire, Halifax Atlantic. Great to see everyone.
Thank you, committee members. And for the purpose of Hansard, I'll also recognize the presidents of Legislative Council, Gordon Hebb, and Legislative Committee Clerk, Judy Kavanagh. So as I mentioned just briefly earlier, the topic today is investment in robotics. And what we're going to do now is have the witnesses first introduce themselves, and then once they're introduced, if any have remarks, we'll do the remarks after introduction. So I'll start kind of to my left here with Dr. Gail Tomblin Murphy.
Thank you. Yes, and I'm the Vice President of Research, Innovation and Discovery, and I'm the Chief Nurse Executive at Nova Scotia Health, and Happy Nursing Week.
That's right. Hi, my name is Greg Bailey. I'm a practicing urologist in Nova Scotia Health. I'm also the head of urology for Dalhousie and the chief of urology for Nova Scotia Health. Nice to be here.
Thank you.
Thank you. I'm Gail Darling. I'm the head of the Department of Surgery for Dalhousie as well as for Nova Scotia Health Central Zone.
Good afternoon, everyone. I'm Eileen MacGibbon. I'm the Vice President for Central Zone for Operations.
Good afternoon. My name is Doug Sinclair. I'm the VP Medicine Quality and Safety at the IWK. In a previous life, I was the VP Medicine at St. Michael's Hospital in Toronto. Had oversight of robotics there.
And I believe we have witnesses in back as well. If you'd like to maybe come to a mic and introduce yourself as well. On Dr. Tomblin Murphy's step, thank you.
I'm Tara Sampalli. I'm the Senior Director in Research, Innovation and Discovery.
Thank you.
Hi there, Nelson Ventura, Innovation Director at Nova Scotia Health.
Thank you. And so at this time, we'll open it up for witness remarks. So I believe Dr. Tomblin Murphy has remarks.
Thank you. And thank you so much, Chair, and also to the members of the Standing Committee on Health. Thanks for this opportunity to talk today about a really exciting opportunity we have in Nova Scotia, and that is investment in robotics. And I look forward for this group to be sharing with you, through your questions, some details. First, about some of the groundbreaking work that's happening in Nova Scotia and how we're leaders in this country in robotics. Also, how it's impacting the lives of people in Nova Scotia, our patients and our families, the economic impact that it is having in terms of the retention as well as the recruitment of clinicians who want to work here and to be trained and use robotics. And also how grateful we are around how quickly we have moved into the global leader in robotics. And we're truly thankful to have Dr. Sinclair as well as Dr. Bailey as well as Dr. Darling here today, and they definitely have brought surgical as well as clinical leadership. From BC to Newfoundland, I think it would be fair to say that people are noticing the innovative technological solutions, and it's not surprising to see why. In a very short period of time, we have 5 surgical robots, and there have been 1,000 surgeries to date. So we have lots of information that we can share today. We have the Da Vinci surgical system, as well as the Medtronic Stealth Auto Guide for neurosurgery, the Medtronic Mazer X for neurosurgery, and the Strikomako, both at the QE2, as well as Dartmouth General for orthopedics. So let's talk a little bit more about this. We don't have Dr. Dunbar with us today, who was unable to come. he would have been otherwise. But we've done over 144 MACO cases to date, 90 at the QE2, and this is focused on orthopedics, 90 at the QE2 and 54 in Dartmouth General. And in fact, it is this minimally invasive surgery and technology that is being used on total knees as well as hip replacements. And when you think about what are some of the impacts, and I'm sure you're going to ask many of those things today, but to have that personalized medicine, something that focuses on you as an individual, those smaller incisions, those reduced length of stays, less scarring, and reduced blood loss during surgery are big. And when you think about getting people back on their feet and enhancing and improving their balance as well as their longevity, as well as other things, that is things like readmitting people and the costs that are associated to have revisions done to some of these things. You're going to ask many questions, and many of them, I hope, will talk about patient impact. And not that long ago, we were able to celebrate Dino DeQuinzio, who actually met Dr. Dunbar. We had a lot of pain. He did work where he was down on his knees in the cold and pipe fitter. And in fact, he went home after receiving a full knee replacement, and I think what he would say, how great is it when I can now go back out shopping with my wife, and his wife Therese was pretty pleased on that. But also, not only does it enhance the impact of people's lives, it also can be life-saving, and that is incredibly important. What I also would like to suggest, and we know from our evaluation, from our research, is that clinicians are trained in robotics. They want to stay. They're not going back to anywhere where there isn't the robotic. And so this brings some of the top minds. It's more than surgeons. We have teams who are wrapped around these surgeons. People, for instance, our physiotherapists, our occupational therapists, our nurses, and many others who are very key to this field. So we see ourselves as we move forward as leaders, not only in the surgery, but in the philanthropy and the donations that are coming in to support our research and innovation in this part of the country. And in fact, the QE2 Foundation, as well as Dartmouth General Foundation, have been incredibly supportive of, and through donations, you'll hear more about those today, we will be pleased to tell some of those stories. The government's action for health plan is clear, but we need to do certain things. And there are three things that we believe robotics are making a difference in are around retention and recruitment, access to care, and outdated infrastructure. As we explore these today, we're happy to talk about each of those issues. So thank you very much for this opportunity.
Thank you, Dr. Tomblin Murphy. Were there any other remarks?
Unless Dr. Sinclair has some.
Oh, sorry, Dr. Sinclair.
Just speaking from IWK Health perspective, certainly in pediatrics, the present status of robotic surgery would be very limited. We don't do any that type of surgery, largely because of the special requirements for children. But again, as Dr. Tomblin Murphy will tell you, there's all kinds of exciting work going on and certainly potential down the road. The same with our gynecology surgery, that's the non-cancer surgery. Again, you'll hear some of the exciting robotic work, but in kind of some of the, shall we say, more routine gynae surgery, not yet, but lots of potential, lots of work ongoing, and hope to be part of this program as it expands.
Thank you, Dr. Sinclair. Any further opening remarks? Okay, seeing none. We'll begin the Q&A kind of period of our meeting today. I think the clerk kind of went over kind of how it works. I'll introduce you, there'll be questions asked by the members. I'll introduce you, your light will come on, and witnesses can speak at that point. Each caucus gets a first round of 20 minutes of questioning, and followed by up to 10 minutes, I think, of questioning after that, a second round. We'll try to stop at around 2:40 so that we can do other committee business at that time. And then at that point, we'll do closing. If you have closing remarks after that, you can do that as well. Normally, we start with the Liberal caucus, so I'll look to them to begin questioning. And I see MLA DiCostanzo has her hand up, so MLA DiCostanzo.
Thank you. Thank you, Chair, and thank you for the opening remarks. I'd like to just say from the bottom of my heart that I know that Dr. Dunbar would be here, and we are very sorry for his big loss. And I was there actually, and I've known his parents for over 30 years. He's an amazing forward thinker who brought a lot of technology, especially in sorry.
I said a great father and
And a great father and husband, but also an amazing doctor that we should be very proud of, and our heart goes out to him for what he's going through right now. So I start with that, and I also wanted to thank all the two foundations, the three foundations actually, the Dartmouth General, the QE2. It's amazing that the focus on robotics and what they've done, really a lot more than what governments have done in the past, is the foundations that really we need to thank today for the money they've raised and for the donors. So we must say that out loud and thank them. And last but not least, I'm very happy to hear about Dino. I've known Dino for 35, 40 years. And not only did he go back, he retired and went back to drive a school bus. And the kids love him. So Dr. Dunbar gave him that as well. So these are the three. And I will start with my questions. My first question is, how are the operations that are using robots being prioritized, the surgeries? Is there a process, and are they being given priority over the old method of operating? If you can just let us know, how are they chosen and what percentages of operations are done via robotics?
So do you want, is it open to all witnesses?
Who's knowledgeable in that field?
So I'll look to Dr. Bailey, and if anybody else has anything to add after, just give me a heads up, and we can add you as well. So Dr. Bailey?
Sure. So it's a good question. I think it's important that everybody in here understands what robotics is, because it's a little bit, when you think about what's happening in the OR room, who's doing the surgery. So essentially, we've had, I'll speak on the Da Vinci robot, and the Da Vinci robot focuses on oncology or cancer cases, primarily in urology, and we do prostate cancer and kidney cancer. And currently, in those particular cancers, it's pretty much doing 100% of the prostate cancer surgery, and I would say about 80% of the kidney cancer surgery that requires a partial nephrectomy, and that means removing part of the kidney and leaving the remainder of the kidney behind. For those very large tumors, other kinds of kidney cancer, we would be taking the entire kidney out, and we would be doing that laparoscopically, which is also minimally invasive. So our open surgery that we do in urology, and we do about 350 prostates a year, our open surgery really has gone away with respect to prostate cancer. Kidney cancer has been pretty much replaced, robotics has replaced laparoscopic surgery for partial nephrectomies. So we do very little open surgery for kidneys as well. For gyne-oncology, the priority is also oncology, of course, and it's primarily for uterine cancer, although there is a move into ovarian cancer. And the priority in that particular patient population are those women who are overweight or obese, who have a much longer course in hospital, a much more difficult time having the surgery done the conventional way. So quite often those women were not receiving surgery. They were being treated with radiation because they were not good surgical candidates. So now the priority is being given to women with uterine cancer, and the uterine cancer is the most common cancer in women. 30% of women who present with uterine cancer would be considered obese with a BMI greater than 30 or greater than 40, and 80% are greater than 30, which is also in the obesity range. So they've done about 200 surgeries in the last 4 years and 2 months, and many of those patients would not have been able to have surgery. So they're prioritized for women and men on our side, women and men who have these malignancies. And that's really the standard of care. It's pretty much everywhere in the country in terms of academic tertiary care centers, centers of excellence are doing robotic surgery for those particular ones. And there's an expansion, and we probably will get into that with other subspecialties as well. So currently, the last 4 years, the priority has been cancer, and that would make up about 95% of the surgeries that are done robotically in Halifax for the Da Vinci. I can't speak on the orthopedics or and perhaps Gail could add something.
Oh, so Dr. Darling.
I would just like to add that in answer to your question about how do we prioritize patients, there's certain indications, as Dr. Bailey has just said. There are multiple more indications for robotic surgery. We are just limited by the availability of the technology. We have one Da Vinci robot so the Da Vinci can do body cavity surgery, so chest and abdomen surgery. I mean, if we had more robotic time, we would be doing more robotic procedures. The procedures that are specifically benefited by a robotic approach are complex procedures, like the partial nephrectomy, as opposed to, taking the whole kidney out is maybe a little more straightforward. I would defer. Operating in the pelvis, so that's why the prostate, why gynecologic procedures, and why particularly these very obese women, because it's not possible to do minimally invasive operations on them because they're just too big. So then they have to have an open operation, and then they're in hospital a week, 10 days, they have more complications. A robotic hysterectomy for endometrial cancer, they can go home the next day, and we're even looking at sending them home the same day. That would not be possible without the robot. And as we have more robotic capability, we'll expand into doing chest operations, thoracic, lung cancer, that sort of thing.
MLA Di Costanzo.
Thank you, and thank you. And actually, you're leading me to my second question. Are we using those robotics to their maximum? You're saying, is it because we don't have enough machines, or is it that we don't have, whether it's beds, whether it's enough staff, nursing? What is causing us? Are we using the machines or the robotic machines to their maximum? Are we using it 30%, 50% of what it can do? If you can let me know, where are we in the usage and the percentage of that it can do more?
Sure. Dr. Bailey.
Thank you. So again, good question. We could be running the robot more hours per day and per week than we currently are. As much of the challenges in the healthcare system now, it really comes down to people. So the people that are required to run it, which would be nursing, technicians, physicians, the nursing and the beds that are required to have the people go afterwards, the post-recovery. There are many cogs in the wheel. So we're using it almost 5 days a week now, but we could be using, we could be doing some extra cases if we had more people to help participate in the teams that are required to support robotics. When we started the robotics program in March of 2019, we tried to estimate how much we would be using it, what our need would be, and we underestimated it. And that's because something happened that's inevitable, and it's happened at other places, and that's called centralization of care. And that means that when we started doing robotic surgery in Halifax, much of the oncology or cancer surgery that was being done elsewhere in the province, and sometimes elsewhere in the Maritimes, was being funneled into Halifax. So our demand went way up, and our activity went way up. So, for instance, to address some of the shortcomings of human resources, the province thankfully has supported the hiring of another robotic surgeon that will be joining the urology practice in the fall, and that's the first new urology position since 1980. Wow! So the demand is there. We can run more with more people, more nurses, and more beds. And hopefully, as we see healthcare improve over the next 3 to 5 to 10 years, and we address some of these issues, we can facilitate that. We could, for the Da Vinci, I think that we could easily run 2 robots full time. And just to give you a quick background. In 2018, when we proposed getting the robot, there were already 31 robots in Canada. The only centers in Canada academic centers was Halifax, Kingston, Ontario, and where Queens is, and Manitoba. And since that time, they have them as well. We now have 40 robots in Canada. So we were pretty late to the table getting a robot. But since we've gotten it, we've caught right back up. And most centers, and Doug and Gail can speak in their experience in Toronto, most centers around the country now have 2 or 3 or 4 robots. Big centers. So.
Could I?
Dr. Tomblin Murphy.
So to Rafa's question, which I think is very key, what we are seeing as we now have the number of robots that Dr. Bailey has shared, and some of them newer than others, we've done over 1,000 cases, as you know. If I add to that the QE2 Foundation as well as Dartmouth General Hospital Foundation, the extent to which, we've got over 1,500 donors who've put their lives, their money behind robotics. That's really important. The $100 million We Care campaign of the QE2 Foundation, a percentage of that is focused on robotics. But where I was going to go with that, Rafa, is when it comes to people and it comes to resources. So as the chief nurse exec, I must say that what nurses are looking for are innovative ways to deliver care. They want to be involved in different things. They want to be involved in state-of-the-art types of things like robotics. And what we see through the investments, for instance, from the QE2 Foundation, about 20% of that actually will come back as it relates to the research and innovation. And so that then, with more innovation, we are able to recruit more people to come and also to stay. So we are seeing through innovative things like robotics, healthcare workers want to be involved in that.
MLA Di Costanzo.
Thank you, and thank you for that answer. I know that we've lost actually doctors because we didn't have the technology and they went to the bigger centers. It not only attracts nurses, but attracts doctors, which is very, very important. But what I didn't get as an answer is the machines that we have, I'm going to call them machines, what percentage of capacity are they being used right now? Do we know? Are they being used 60% of their capacity compared to what they're being used in the US, for example, for the same machine?
Dr. Darling?
Thank you. That's a good question. I think it's probably being used about 80% of its capacity, limited only, as Dr. Bailey said, by human resources to run the machine. Of course, if we wanted to run it more, we run it all through the week, 7 days a week, we could probably use it even more, but I think that people need their time to recover. Faculty, staff need time off, so. But to Dr. Bailey's point, we could certainly use at least 2 robots, even just to cover the urology and gynecology practice, not even beginning to bring in the new work, the colorectal surgery, the thoracic surgery, and head and neck surgery.
MLA Di Costanzo?
Thank you. So that brings me to the next question, which is the hip and knee, and I was hoping that, to ask somebody who actually works on those. The wait times right now, it's 843 days in Halifax for a hip replacement. That's one of the examples that I have here, and it was in the election promise that to have wait times down to the national average of 18 months. So where are we with that? And was that a realistic goal to have announced that during the campaign?
Dr. Darling?
Thank you for your question. Everybody's very concerned about wait times, and I think it's a big source of moral distress for doctors, surgeons. I would point out that before the pandemic, that the wait times for hip and knee replacements were actually almost at the national average, and obviously, like everything else, was thrown off course by the pandemic. So we are really only now getting back to normal, but having even though we still had slowdowns because of COVID earlier this year, our wait list is down by 16% just in this past year, and the target was to do 2,500 more cases. Now that's all cases, not just hip and knee cases, and we've done over 5,000. So, we are making progress. with regards specifically to the hip and knee patients, traditionally, those patients would have stayed in hospital 1 or 2 nights at least. We're now doing almost, well, huge majority, 75%, as day patients. So they come in, they have their joint replacement, they go home the same day. So the people that are waiting a long time right now are people that couldn't be done as day patients. They, because of other medical issues, would have to stay in hospital overnight. It's what we call long waiters. And so now that we have the beds opened up from COVID, we're now in a position to start getting those patients done as well. And we've, particularly with the strategies that Nova Scotia Health has used, where we're doing the straightforward joint replacements primarily at Dartmouth General and the complex or revision joint replacements at the QE2, we're able to really increase the throughput of the first-time joint replacements, if you will, at Dartmouth General. And we now have 4 orthopedic surgeons there doing arthroplasty surgery. We also have arthroplasty surgeons at the QE2. So we are impacting, and we have a lot of confidence that we're going to bring that wait list down to the national average very soon. And so I think it was a realistic position to take.
MLA, oh, sorry, I see, is it okay Dr. Sinclair answers as well?
Yeah, maybe just another comment to amplify that. I mean, when you look at surgical wait list times, right, I mean, they require multiple things. Dr. Gail Murphy and her team have developed an e-referral system that's really quite revolutionary, that will funnel research. And then as Dr. Darling has said, it's that management of the wait list. I mean, surgical robotics is a very exciting area and has excellent outcomes for those patients that get it. But let's be clear, that's a very small percentage. The surgical wait list issue is, I shouldn't say almost another topic, but this is a component that, you know, we did have a previous session on that. We could talk more. So I think the surgical wait list issue has multiple components, of which, you know, robotics is an important, but only one piece.
MLA Di Costanzo, you have about 2.5 minutes.
Okay, so I'm going to keep it on the political part, and I apologize for that. So if they announced the election was during COVID, so they knew the limitations, what COVID was doing, and they still announced that, right? Is that realistic? That was my question. And also, if you think it's going to, can you give me an approximate time so we can give them an extension of that promise? So you said soon, but what do we expect soon to get it to the national average? That's what I'm hoping. If you can just maybe end it with this until my second round.
Ms. MacGibbon?
Thank you, and thank you for your question. And as Dr. Sinclair said, I think it is really important to talk about wait times for surgery in a broad-based way. Robotic surgery is a strategy that enables us to have better use of beds, better use of facilities and sites, so that we can perform surgery in the most appropriate setting and use our settings as optimally as possible. So your question about wait time and how long it will take, this year we have a very aggressive plan for the achievement of, as Dr. Darling said, 2,500 additional cases, and we're on track to meet that target. So our intention is that for hips and knees and their wait times against what would be considered national average or national targets, we should be seeing those kinds of results by this time, say next year and then the next fiscal year, because we really are moving at a pace that's much different than we have been over the past, 3 years due to COVID.
MLA Di Costanzo, about 40 seconds.
I just want to say thank you, and I'm sorry to give you a bit of a hard time, but I really wanted to make sure that we're on track with that. And I have a few more questions, but I guess I can leave it to when I have more time. Thank you.
Okay, so I see MLA LeBlanc's hand up. So MLA LeBlanc, your 20 minutes will start now.
Thank you very much. I just wanted to know if Dr. Sinclair recognized this robot from the IWK. Is he still around? It was like a thrilling moment when I went to the blood clinic at the IWK, and this guy was programmed to talk to my daughter. It was really fun. Anyway, helped us get the blood drawn, I guess. But I wanted to pick up just on a couple things Dr. Bailey was talking about, because I just find this super fascinating in terms of the women's health aspect. So I just want to ask a couple questions around that. So number one, just to clarify, so if a woman has a too high BMI, so is considered in like obese categories, then she was not able to get a surgery for uterine cancer or ovarian cancer because it's too risky, and therefore just getting radiation, and therefore would you say that the case is that people that are in high BMI categories are having worse outcomes in terms of those cancers?
Yeah.
So Dr. Bailey?
So there are basically two groups. So there were women who were obese enough that they couldn't have a laparoscopic procedure, and they would require an open procedure. And with an open procedure, instead of going through 3 or 4 small holes, you're going through an incision maybe this big. That requires a long length of stay in hospital. There's good evidence, and there's lots of publications on the increased risk of bleeding, post-op recovery, pain, wound infections that go on and on and on. There's a lot of costs associated with that. But there's also some outcome on cancer outcomes, so cure outcomes and that kind of thing. The second group were the patients that were too large in body size to undergo an open surgery. So even too big to do an open incision, so the obesity factor was much higher. And those patients were being given radiation and or chemotherapy. This is a little bit out of my area of expertise, but this is my understanding. I've talked to the gynecologist about this. And that would be considered an inferior treatment than having a surgical removal of that. But that was the safest thing for them. And now those patients can be treated with robotics and be out of the hospital the next day. So they're getting a better treatment.
MLA LeBlanc.
Great. And so, and you said about 30%? You can just nod on that one.
Dr. Bailey?
Yeah. 30% of women with endometrial cancer meet the criteria for morbid obesity, 80% for obesity.
Okay.
MLA LeBlanc.
Great. And then so would you say that women's health is now vastly improved because of this Da Vinci robot?
Yes.
Dr. Bailey?
I would say the management of uterine cancer has vastly improved.
MLA LeBlanc.
Okay, so I just wanted to clarify that, and I also wanted to know, so you also mentioned that if, and this is like outside of the scope of just women's surgeries, but in terms of the Da Vinci robot, you could see it be 2 robots being used full time, and if that was the case, just say we had those 2 and we had the people, or no, sorry, we had the 2 robots. What would we need to have, like on top of that, to make that happen? And what was my other question about that? Oh yeah, and how would that, like what would impact would that have on health, on wait times and health outcomes, and like how would it relate to the general surgery wait time lists that we're looking at?
Dr. Bailey.
So in oncology, regardless of what specialty we're talking about, there are wait lists and wait times. So we work on wait times. There are standard national averages of what's acceptable to make a patient wait to have surgery. It's different than wait times or wait lists for, let's say, knees or hips. So for oncology, we try to live within those wait times. And in order to do so, the robot that we have now, we try to maximize the use. And we have several surgeons who are trained to do it. They can only work so many hours a day and so many hours a week. So for example, the 2 robotic surgeons that we have now, they do 2 to 3 days of robotic surgery per week each, sometimes in combination and often on their own. They have to see patients on other days to manage non-surgical things. We have an opportunity, and currently I did ask for the wait time. So in the last 12 months, in 4 years, we've done 960 cases on the Da Vinci robot. In the last 12 months, we've done 307. So our efficiency of cases has gotten much better. We're doing more volume per time. And we've maxed out the surgery that these guys can do. We still have, as of yesterday, as of last night, 107 patients waiting for prostate or kidney surgery on the robot. And I have 2 or 3 surgeons to do them and who are working full-time. And each week we get more and more referrals. If we hire more people, more surgeons, we have more nursing, support staff, anesthesia, and also the capital to purchase more equipment and the operational funding to run it, then we can do more. I think that many centers around the country have also, not just in the last year, but years ago, have gotten into doing colorectal surgery for the exact same reason. Much, much better for the patient, much quicker recovery, better outcomes, less bleeding. Thoracic surgery and cardiac surgery. We haven't even delved into that yet. If we do, which we want to, I assume that we will have 2 Da Vinci robots, running full time.
MLA LeBlanc.
Well, thanks. And I mean, I guess all of this points to this big question, which is why, if this is all the case, then why do we rely on hospital foundations to make to raise the money for these robots? Like, does it not seem like this should be part of the standard of care that we now have come to enjoy, but also come to rely upon? And so I'm wondering if anyone, perhaps Ms. MacGibbon, can you speak to that? Because it seems to me that relying on health foundations or hospital foundations creates a huge inequity in healthcare in Nova Scotia. So for instance, I represent a community where like one elementary school has all kinds of money to buy the best playground equipment in the world, but the rest of the elementary schools in my riding like have crappy playground equipment because there's no special fundraising happening, and they rely on that small amount from the HRCE. So how does that sort of comparison work with this type of technology in our hospitals? And if Dartmouth General and QE2, which are great, like, don't get me wrong, great organizations, if they're able to fundraise better, does that mean people in Yarmouth and Cape Breton are not going to have this type of technology and these better outcomes?
Dr. Sinclair, I saw your...
Start. So I think it's an excellent question, and as you can imagine, at the IWK we have this debate and discussion all the time. Our new emergency department's government funded. Previous pediatric ICU and neonatal ICU were fully fundraised, right? But I think that's what's unique about the robotics program, in that what we really want to do under Dr. Tomblin Murphy's leadership is say, and this is what donors want. They want to be involved in innovation and what's new. So the challenge is we need the foundations to have a really important role to kind of test out some of these new technologies. But as Dr. Bailey said, where we are now with robotics, it's moved beyond that stage. There are some areas, of course, like orthopedics, but as Dr. Bailey said, and I have the same experience when I was at St. Michael's, it was over 15 years now from when they started. The robotics area in urology and gynecology is well established. So you're right. I mean, that's an area that should be moving into more capital funding, where and the foundation should be focused, as they always have been, on the innovation side. So, and it's always a balance, right? We've always been underfunded capitally in health, in our healthcare. I think we've seen changes in the last few years across Canada in that. But it's an excellent point. Is how do you get that right?
Ms. MacGibbon, I see you. Yep.
Yeah, I just want to add a few points. It is an excellent question, Sue, and I think what's most important to remember is that, when you think about the comments Dr. Bailey made about Da Vinci's as they were purchased across Canada, they were all purchased by way of foundation support, every single one of them. And I think, as Dr. Sinclair said, it's the balance to use high-tech capital dollars in the most balanced way possible, so we would shift and make priorities within areas that wouldn't enable enhancements and advancements like robotics to be possible, so that those strategic partnerships have enabled. But as we move forward and as it becomes more of what we consider to be a standard of care or an expectation of standard of care, I think we'll start to see a definite shift, as was mentioned, on how we invest and where those dollars are coming from. I think, as was mentioned, donors are excited and they get excited about innovation like this, so it was a win-win for us to have foundation support in advancements with robotics. But going forward, I think that will change.
MLA LeBlanc? Oh, sorry, I see Dr. Tomlin Murphy.
Thank you. And if I can just add to those 2 points, I think that from a donor's point of view, again, they are interested in the innovations. But in this province, we're pretty fortunate. We have 42 healthcare foundations, and as much as we think that some of them are small, some of them actually have more money than some of the bigger ones. And I think that, to your point, Susan, Stephen Harding chairs that group of healthcare foundations, and I have seen over the last 4 years how they're actually working together. So donors around robotics are also interested in things like the training piece and the education, and so innovation around using virtual reality to actually, you know, for people to put on the headsets. These are learners, these are providers across this province are really, really important. Business cases that go forward to foundations as well, they don't go forward as just looking for donations, but in fact, as Nova Scotia Health and our responsibility, we do this by year, and what those maintenance costs are going to be, what the operating costs are going to be. So when we come to the table with the board, for instance, of the foundations, that Nova Scotia Health is also bringing to them their commitment for these ongoing pieces to make sure it is sustainable, as opposed to a drop in the bucket, some technology. We're also hearing from the foundations, again, with their, for instance, $100 million campaign, We Care. Robotics is an area that our foundations across this province are interested in having a piece of and investing in.
MLA LeBlanc.
Yeah, I understand that, you know, donors like to donate and people like to give and people like to be involved. I just think that if something is changing the course of healthcare and like making sure that women are not dying of cancer at a, like, you know, out of proportion rate, then we should probably just be paying for it with our public purse. Anyway, that's, we could talk about this forever. I want to go back to wait times for hip and knees. So first of all, I just want to, we've been talking about national averages, but is that the same as a national benchmark? Because it doesn't feel like it's the same, but are we interchanging the word benchmark and average? Because okay, good. So we have the benchmark for knee replacement surgery is 182 days. So it seems much less than what my colleague was talking about in terms of an average. And that was the target that the government was, that had promised to meet after 18 months. We've now passed the deadline of 18 months. And we know that the surgery wait time for knees is 1,372 days, almost 4 years, and that's not counting the consults in advance. So I'm wondering if someone can talk about this, perhaps Dr. Darling, you know, what is this situation? Why are these numbers so startlingly high? And what, like, how does the robot program, how is that impacting these numbers?
Dr. Darling?
Thank you. I think the robot can impact this by 2 ways. The orthopedic robot allows the surgeon to be very precise in how they put the screw in and so on, and they enter in the data into the computer before the patient is even, you know, asleep, so that the operation is basically thoroughly planned, accurately planned before it even starts. And so, and this may be a bit disturbing to non-surgeons, but, you know, the idea of, you know, tapping a screw in and going, oh, that's not quite right, and readjust it, you know, like, right? That doesn't happen with the robot. So we can do the procedures more precisely and in shorter time for each procedure, because it's all planned out, and you know, the robot adjusts the angle just the right way so that the screw goes in exactly perfectly the first time. So that's one way it helps. The other way it helps is because it's more precise, there is less need for revisional surgery. And so you're not having people coming back to have that redone because, you know, it wasn't quite right the first time. So the robot does help with that.
This is how the coffee spells.
MLA LeBlanc.
Pick up the technology. So yes, thank you for that. But I'm actually asking about real numbers. So in terms of our wait lists, at the QE2, for instance, and this may have already been said, but I'm trying to think about it in real time again. But like, we've talked about like post-COVID that we're catching up a little bit. But in terms of the use of the robot, how is that cutting into the list? How much faster are things happening because of it?
Dr. Darling?
I think that it's not being used for every hip and knee. So that's the first thing. So not every hip and knee is being done with the robot. The acquisition of the robots for orthopedics is relatively recent, so it's just coming into use. I think that the orthopedic group is actually very well organized and very efficient at how they strategically book cases to maximize the throughput. So the robot can help to a degree, but it's not for every patient, it's not for every case. So it's just one part of their strategy for reducing those wait times. I think the other part was just going to the same-day surgery where they could come in, have a joint replacement, and go home the same day, so we weren't dependent on beds, and that has made a huge difference in terms of getting patients through the system.
MLA LeBlanc, it's a little less than 3 minutes.
I guess I'll just stay on this then. So, again, I'll go back to that startling number of 4 years waiting for a hip or a knee replacement. What has contributed to that? Like I'm sure it can't just be COVID. So is it that we are lacking clinicians? Is it the nursing shortage? Is it that our population is aging and so there's more people that need them? Like why are we waiting 4 years?
Dr. Darling?
Yes, it's multifactorial for sure. Aging population for sure. Obesity for sure. We know that people who are overweight are more likely to have joint problems. So yes, there's increased demand. Up until COVID, these patients all required an inpatient stay of several days. So then we get back to the bed issue. So I think that some of it is related to the old way of doing things, if you will, made things, you just couldn't put patients through the system as fast as we can now. I also know that wait lists for individual surgeons vary quite a bit. So some surgeons have like 500 patients on their wait list waiting for a joint replacement. With the Ocean e-referral system, we will try to even out those referrals. Within the orthopedic department, they're trying to redistribute some of those referrals, but you can imagine patients saw Dr. So-and-so, they want their surgery done by Dr. So-and-so, not Dr. X. So they are giving patients the option to go to a different surgeon who has a shorter wait list. So they're working on it, that's all I can say. And based on what they did before COVID, I'm confident that they're going to be able to get that wait list down, significantly impacted within a year.
Oh, I see Ms. MacGibbon.
One thing to add, Susan, I think I mentioned earlier about the optimal use of locations. One of the things that will come by way of us having increased access and use of Scotia Surgery as a facility on the Dartmouth side, and the Dartmouth General Hospital is very progressive and innovative with respect to use of their site as well, as evidenced by the work they're doing with robotics too. That enables us to use the sites that need inpatient beds when we need them and access to those sites in the most efficient way. That's something that's relatively new in terms of the number of sites that we're optimizing in the current year, so that will assist with the current wait list and achieving targets.
Order. That was good timing. Order. The time for the NDP first round is expired. We'll move on to the PC party. I see MLA Palmer has his name up, or his hand up, so go ahead.
Thank you, Mr. Chair. Today's an example of a day that I'm just excited to be on this committee. just to get a chance to hear some of the innovative things that are happening. And I'm sure healthcare today looks different than it did 20 years ago, and I'm sure 20 years from now it'll look a little different in how things are done. So I'm sure like a lot of Nova Scotians aren't aware of a lot of the things that are happening. So our job is to really communicate some of these things to Nova Scotians. And thank you for outlining some of the things about progress in wait times that innovation in robotics is making, and the shortened convalescence time in hospital. It's important for people to know some of the things that are happening with robotics and innovation. My question is a little bit general and broad. My first question, basically about the process that brings these world-class technologies to our province. Can you just tell us about that process, and maybe Dr. Tomblin Murphy and anyone that would like to add to that? But how does that happen? How do you kind of decide what would be the next robotics to come along, and just talk about the process more?
So thank you.
Dr. Tomblin Murphy.
Yes, thank you, and thank you so much for that question. And a diligence process is incredibly important. And diligence for us means that we have patients and families involved in the very beginning conversations around things like robotics. We also have our clinicians. We have about 28,000 employees in Nova Scotia Health, and we've got some brilliant employees who have good ideas. They've seen other experiences, and they know the evidence. So we bring the patients and the families, we bring the clinicians to the table, and we bring our private industry partners. And so, many have thought about whether we're talking Medtronic, whether we're talking about Stryker. It doesn't really matter that our private industry partners are key to this. In addition, we bring our foundations to the table. So what is it we do? Well, in our portfolio, we have an opportunity to do market scan, and we do market scans pretty quickly. What's out there? Who's using what? What impact are these robotics actually making on patient care, as well as all of the health system outcomes that people have asked about so far? And so we can do the market scan, and then we do the diligence process. So we have many private industry partners who have many different kinds of technology. And so then for us, it's important for us to do the diligence, the business diligence. And so we have business development and have invested in business development in this province to make sure that we are making the right decisions about the best products. And so the diligence means then having criteria that are set ahead of time, that we look at that best evidence, we look at the market scans, we bring the clinicians together, and we do demos. And so, for instance, where do we do those demos? We would have people come, and in the basement of the Bethune building, for instance, we have clinical simulation that the QE2 Foundation has generously supported. In addition, on the Dartmouth side, Dartmouth Hospital, as well as other foundations across this province, have the simulation type of experience. So we can go in, bring our clinicians, wrap around, get a feel for. So Dr. Darling has talked about, the personalized medicine, getting that screw and making sure that that arm is actually working in the way that surgeons think it should be working, for instance. So diligence means a lot of things. We have the criteria, we bring the people to the table, the market scans, and we make the decisions about those best products. And then our private industry partners, they stay with us. They help us. They help us with all of the other people at the table. They oftentimes, and we see value in those partnerships, they make contributions to research and development, or research and innovation in this province, which helps us, again, to use that data to understand the research, and we wrap our clinicians around much of that research. So it's quite an extensive process that the decisions don't come easy, and there's a lot of people involved and a lot of evidence.
MLA Palmer.
Thank you very much for that. I'm sure a lot of people are around the province in rural areas. They're taking advantage of these opportunities for robotic surgeries when they come to the city or the bigger hospitals. So robotics, innovation in general. Could you talk to me a little bit about some of the things that are being done to promote innovation and maybe robotics in other rural parts of the province as well, and places like where I am in the Apis Valley? But maybe talk about how those rural people are able to take advantage and be benefiting from this technology.
Dr. Bailey?
Yeah. So, we're pretty fortunate here in Nova Scotia, based on our geography, our size, and our population. We're all pretty much very well connected across the four different zones. So people have access to robotics in Halifax because we have representation all over the province. So in each zone, there's pretty much a representation of each of the subspecialties. So urology, general surgery, orthopedics. And so those patients are often seen by their local urologist, for instance. If they're diagnosed with a prostate cancer or a kidney cancer, they would be referred on to Halifax where that particular surgery would be available to them. So there's absolutely no discrimination at all or difference in access to care amongst patients who live in different parts of the province. And I would say that's for most things. And that's why we, as a tertiary care center, 20, 30 years ago, you would have a lot of different surgeries being done in all corners of the province. That doesn't happen as much now, and that's a good thing. You don't want a lot of people doing a few things. You want a few people doing a lot of things in terms of surgical volumes and outcomes, and that's proven. That's evidence-based. So access is the same regardless of where you live. Yeah.
Dr. Darling, I saw your hand up.
Thank you. Thank you I just wanted to add to what Dr. Bailey said about access. There are certain specialties in surgery which are only offered in Halifax. Thoracic surgery, vascular surgery, cardiac surgery, neurosurgery. And so we're used to having patients come from all over the province to Halifax for those procedures, and that allows the utilization of the operating rooms in the other communities to be used for things that are more common, what we might call bread and butter surgery, but things that those people in those neighborhoods need every day, every week. And then they come to Halifax for those tertiary level care. And so they have access all the time to that care, whether we do it robotically or some other way. That's available.
Dr. Tomblin Murphy, I saw your hand up as well.
If I can just add on the innovation piece. So if we look at the recent investments of our academic institutions in this province, so leaders like St. FX, like CBU, like St. Mary's, as well as others who have the innovation, not only just the programming, but the spirit and the responsibility to be involved in. It's a good day for health and health system, because robotics also have to do with our biomedical engineers, like Dr. Janie Wilson, who works with Dr. Mike Dunbar. We also know that it means that data and analytics around that data. So the robotics, having the most in the country, and the data that every day on every patient, and that's only going to increase, that the work that we're doing across this province with those academic institutions as an example will continue to put us on the map. And that's incredibly important, those investments.
And Dr. Sinclair, I saw your hand up as well.
Yeah, I think there's some lessons learned from colleagues south of the border, where robotics has been quite expansive to all kinds of hospitals. And I shouldn't say it's a marketing ploy, but they've really expanded without any kind of thinking because of their different system. And I think certainly, in Ontario, they struggle a little bit with that, but kind of kept it sort of under control. But I think that's why we have such an excellent opportunity here in Nova Scotia, because as Dr. Bailey said, everything's so well connected, and we can make sure that we have the expensive technology, in the right place and have the patients in the right place, because again, we're connected and it's a small province. So I think that's a real advantage that we have here.
MLA Palmer.
I just want to thank you all for your in-depth answers, and thank you for highlighting this for all Nova Scotians today. I'm going to pass this on to my colleague, MLA Barkos.
MLA Barkos.
Thank you, Chair. So, Dr. Sinclair, in your opening statements, you had said potential, that you see lots of potential. And I'm just kind of wondering, I'm inquisitive, what you see, what the potential is.
You mean Dr. Sinclair?
Specific in pediatrics?
Yes,
Is that?
yes.
Yeah, I think it's still very early days in that regard. Again, because if you think of pediatric surgery, smaller numbers, obviously smaller numbers of surgery and smaller patients, if you will, from a physical point of view. So I think that's very early. I did have some contacts. In preparation for that, I did make some contacts at Hospital for Sick Children. Again, even a world-class place like that, it still is very much more on the innovation side. So I think there's more to come, but I think it's still very early days. I think we'll see developments. We didn't get a chance to talk about some of the very exciting areas in neurosurgery and neurointerventions. I think you'll probably see that expand before pediatrics, but who can predict these things?
MLA Barkhouse?
Fair statement. Could anyone please share with the committee a bit more about the Centre of Excellence strategy?
Dr. Tomblin Murphy.
Thank you, and thanks so much for that question. And a Centre of Excellence strategy around robotics is one that brings together some of the answers that we've already talked about. So it has to do, first and foremost, on improving experiences and patient outcomes. And we've heard a lot about those today. And that this will continue to be a focus of the strategy. In addition to that, it's again using a Centre of Excellence as a teaching organization, so that we bring, I've oftentimes heard that we bring the best, we bring the finest fellows. We are now seeing them in our medical schools before they become fellows, as well as in other health-related professions. They come again to be trained in robotics. So we know that as we move forward in the innovation, in the data pieces as well as other, this is going to continue, and it's an important part. But there's also the education and training is more than what we're doing right now in classrooms, and more than what we're doing in clinical placements, and more than what we are doing, for instance, in simulation labs. That part of the strategy is using innovative ways, so whether it be virtual reality, which I've spoken a bit about, but it's also across this province, for instance, as we move forward with mobile kind of simulation, so that whether you're in rural parts of this province or if you're downtown Halifax, the learning needs to be accessible. So part of the strategy is how is it that we actually do that education and training. As well, the strategy, incredibly important, is again around the innovation piece. So I think Dr. Sinclair talked about some of the recent examples as relates to brain and spine kinds of robotics, and others that we're talking about that have to do with epilepsy and other things. Every day there's something that's coming forward. So a strategy, a Centre of Excellence strategy, is where that best evidence and the best partners and those best outcomes and how we train people come together. And so that would be part of the strategy. It's more than buying robots. It's having robots, but also having a strategy that I think Dr. Sinclair was just referring to, where in the South, they've gone wrong, and I think we're here with a strategy that is going to make a difference.
MLA Barkhouse.
So then you gave us a little tidbit, but that leads me to ask if you're able to give us an indication or a sneak preview of some future projects coming out of the Innovation Hub, and what exciting work are you up to right now, I guess would be a great explanation.
Dr. Tomblin Murphy?
So I definitely will get started, and I think definitely that there are many, many solutions to transform healthcare, and some of those solutions within the Health Innovation Hub, we have a model to test and try. Let's try things, let's get some people in through the door, let's do some diligence, and let's figure out whether they work or not. So examples around robotics, for instance. So if you think about what Dr. Sinclair has said, we're much better set up today where we have more robots, we have people thinking about the innovation, for instance. So the testing and trying additional kinds of robotics that would make a difference to impact the lives of Nova Scotians. Dr. Darling has talked about and given a sneak preview in terms of the impact on thoracic surgery. Dr. Bailey has also talked about, if we had another Da Quincio, oh my goodness, Da Vinci. If we had another Da Vinci robot, just think about what we could do, right? So the sneak preview into the work that we're doing around health innovation is what are the pain points, what are the needs of Nova Scotians, and how do we need to be doing things differently? And the test and try models are parts of that. Sneak preview is also a center of excellence, means that we can't just say we have one, but in fact that the QE2 Foundation has made generous board decisions around, as well as the Dartmouth General Foundation, as well as others, on the types of funding that we need to continue on this journey.
MLA Barkhouse, you have about 5 minutes.
Well, I'll pass it on. There's 4 of us, so I'll pass it on to my colleague, MLA White.
MLA White.
Thank you. I just want to say how amazed or impressed I am on this topic. This topic really is opening my eyes to a lot, and I feel very privileged that we get to sit here and have this conversation and the briefing notes we've had beforehand to know what's so exciting, what's going on in Nova Scotia. You folks are amazing, what you're doing, and I'm just honored to be here with you to hear this. I truly mean that. So the reason I say that is because one of the things you talked about earlier was changing hospital recovery times from 10 days, a week 10 days, down to 1 day, and now being released in the same day. So the only question I want to ask you for now is if you can maybe give us a little more elaboration on some of how robotic surgery is truly impacting the patients, because that's what it's about. Ultimately, that's what we're here for, and that's why we're doing this stuff. So can you tell us maybe a little bit about how the robotic surgery is helping patients, and maybe you have some personal stories of people that you can, of course, keep confidentiality, but just the impact. I'm truly amazed by that.
Dr. Bailey?
Yeah. So, I mean, I think that's been one of the most satisfying parts of bringing robotics into Halifax and into our practices, observing the patients and the outcomes and the experience that they've had, and they love to share it. So, up until we did robotic prostate surgery, the average length of stay was 2 or usually 3 days, and now it's typically less than 24 hours. Patients go home taking Tylenol, if anything. They have very little pain. They're up walking that night, and they're up walking out of the hospital the next day, because it's done through 4 very small incisions, ½ an inch long, versus a 4 to 6 inch incision. So the recovery in pain, discomfort, everything that goes along with it, it affects your mood, it affects the painkillers, affect your bowel function. The recovery at home for everybody is prolonged when somebody's had a big surgery. When someone's had a smaller surgery with less pain, everybody recovers better. In the surgery itself, there's less blood loss. Everything is precise. There's risks associated with blood loss and blood transfusions. We rarely see blood transfusions now with our surgeries that are done robotically. There's less risk of infection, which goes on to reduce the complications associated with wound infection and everything that goes along, less risk of need for antibiotics. And there's a quicker return to society or to society contributions, so going back to work and participating in society. And that's not something we can measure, and it's not something we can measure, but we can't measure it financially from a health point of view. It comes from a different bucket of money. But that's important to patients. Up until we had robotics, those in Nova Scotia who were wealthy could go to the States and have robotic surgery. They could go to, they could fly to other parts of Canada and have robotic surgery. That's not very common now. But the average person couldn't pay $50,000 to go to the States to have, so we were limiting, so our healthcare was really 2-tiered, even though we didn't know it. And one of the reasons that the donors came to the table was, what they explained to me was, as donors, a lot of the bigger donors, although the majority of donors were people that gave $25 and $50 and $100, but some of the bigger donors said, we're doing this for our employees. We're doing it because we can go anywhere. We can go to the Mayo Clinic or wherever, but our employees can't. So that was a really big, that was eye-opening for me. And that's the majority of Nova Scotians. So when you reduce the time in hospital, the other thing that happens is you have less canceled surgery, because every day we come in for surgery, we wonder, are there enough beds for the patients that are booked for surgery that day? And if there are too many patients in the hospital, then I might have to make a decision on canceling one of my patients that day. We don't see that as much now. Yesterday, Dr. Rendon did 2 prostates and a kidney before 2 o'clock in the afternoon, and all of those patients went home today. 5 years ago, it would have been very different. They'd still be in the hospital between 3 and 7 days. So we've opened up beds for more people to come in. So that would be an example of the impact it has on patients.
MLA White, you have 5 seconds.
Quality of life impact, work labor shortage, all those things are impacted.
Order. The time for the PC party's first round is over. I see MLA DiCostanzo has her hand up. We have 10 minutes for each 10 minutes for each caucus. So MLA DiCostanzo.
Opening remarks.
MLA DiCostanzo.
Thank you, Chair. And I'll just continue on that quickly. I have other questions, but to me, and as my colleague LeBlanc mentioned, that this is about efficiency, right? You're just telling me how much time it saves, how much this. So why are you waiting for donors and not as government? This is not about, helping just the employees. This is how we can do things more efficient. So we save dollars for the government if we go the robotic way, right? So this is where we should be heading. If it, for the patients, for this, it has so many other wonderful things, but to look at it from a dollar value, it is the way to go. And we shouldn't be waiting for foundations to do it for us. So I agree, and that was something I was going to say earlier on, but that was that. The other thing that I really also wanted to ask, especially, is the redevelopment, the QE2 redevelopment that was announced in 2017, and I remember that. I was so excited because robotic is something new that brings doctors. New hospitals brings new doctors as well. Has that redevelopment was envisioned for better space for robotics? Has there a vision for, and I know that 2 parts of it has been continued, which is the Dartmouth side and the Bayers Lake, but they've stopped the QE2. What is this QE2? What was the plan for QE2 when it comes to robotics? And what is happening at Bayers Lake for robotics? If you can tell me, I can tell my constituents. So I would love to hear that part as well.
Ms. MacGibbon?
Thank you. It's an excellent question and something we're very excited about. I think the announcement in January to do more faster has the entire team at every level and every team excited about the possibilities now in a shorter time frame. What you're asking about specifically with robotic surgery is part of the planning now, because we know we're making changes to our operating rooms at the QE2, which is where we would be doing robotic surgery in addition to the Dartmouth General. And the planning that's underway is to determine the best ways for us to optimize the space we have to enable us to have the capacity we need for the future and to give us all of the extra elements that aid in that and support a growing robotics program into the future.
MLA DiCostanzo.
Sorry. So, but the redevelopment, the 3 location, we're bringing services to where patients are, was in the plans in 2017, and as you, to have robotic rooms, and how does space and new hospital affect having more robotic machines, more using maximum capacity of the robotic? Does that help? Or what is in the plan? Is there going to be day surgery at Bayers Lake Outpatient Center with robotics for the future?
Ms. MacGibbon?
So our plan right now is not to have robotic surgery at Bayers Lake. We would need, the resources we would need currently would make more sense at the QE2 and the Dartmouth General, but that's not to say that we're not, as we talked about earlier, optimizing all of our sites to ensure we're doing surgery in the most appropriate location to get the best utilization. Originally, there wasn't a plan to have enhancements to our operating room theaters at the QE2, but that is now part of the plan. So People think, I think there's a misconception that we need to add a lot for robotic surgery, but as Dr. Bailey can attest, it really isn't huge enhancements. We've done a lot with what we have, so it's not as though we have to do a lot to the physical infrastructure to enable added capacity. It's just generalized added capacity that we are working towards, but robotics is obviously part of that planning.
If I could just make a quick...
Oh, Dr. Bailey.
It may help. So almost all robotics equipment is a plug-and-play model. They're on wheels. You wheel them into any operating room, really. I think that there are some modifications that we're talking about making to some of the rooms, and we anticipate an expansion of robotic surgery, but it's quite remarkable how these are set up to be able to wheel into any room. The room that we have it in, the VG, is about the size of this table. It's a small room, but we can do everything we need to do. The new OR rooms are much bigger, and we'll be prepared for that. And when we need the room for something else, we unplug it and roll it out.
MLA Di Costanzo.
That's wonderful, and I hope the new hospitals will attract more doctors who are more, able to do robotic surgeries. I'm also wondering about the training, how the old doctors, I should say, who are trained to do it the old-fashioned way, are they resistant to doing it with robotics? How much resistance do you get? And can you train all doctors on robotics? What percentage is being trained?
Dr. Darling.
That's an excellent question. As an old surgeon, I can probably answer that very well. We already have surgeons who are trained on robotics who are not using robotics because we don't have it yet. So, for example, colorectal surgery. We have 2 surgeons who are currently trained to do robotic colorectal surgery. They have a plan, if and when we get another Da Vinci robot, how they're going to train their colleagues. And most of these training programs, the Da Vinci Intuitive that owns Da Vinci takes surgeons down to their training site, they train them up, and then they send proctors to that surgeon's home hospital to supervise them, to help them as they start their practice. But we already have surgeons on site who know how to do robotic surgery, both in colorectal and in thoracic surgery. And so we already have a plan for how we're going to bring those other surgeons up to speed on robotics. I think there will always be surgeons who don't necessarily want to embrace the new technology, but they're not standing in the way. They're not a barrier to the other surgeons learning. And it's always good to have somebody who knows how to do it in an open fashion just in case. But we already have a plan for how we're going to train those new surgeons. And there is a simulation trainer for the robot so that before anybody actually, like for example, surgical trainees, before they start on an actual patient, they are going to be down there training all the time, learning how to use it before they ever go to the operating room. Once they're in the operating room, there's a dual console for the surgeon who already knows how to do it and the resident or trainee who's learning how to do it, and the surgeon at the console who controls everything. So it's a very safe, it's incredibly more safe than the way we used to do it.
MLA Di Costanzo, and you have about 2 minutes.
Perfect. Thank you. And that says a lot that we need a couple of Da Vincis. Many Italians here are going to do a very good job. So what is the dollar value of another Da Vinci? And with a $1.6 billion that we just had, extra money, why didn't we have another 1 or 2 Da Vincis when it makes efficiency and it actually saves government money? So how are we not advocating for that as doctors, as people, that this is the way to go? Is it 2 million, 3 million for a Da Vinci?
No, I bet it's way more than that.
Okay, that's my question is, how much is a Da Vinci?
Dr. Bailey.
The original Da Vinci that we purchased in 2019 or 18, the entire business plan was $8.2 million, of which I believe $3 million was for capital, and the other $5 million was for maintenance and disposable or consumable equipment. Those costs have come down, fortunately, so our business case, we actually were able to do more cases than we had targeted, because the costs have come down each year. And there's, up until now, there has been one player. It's been Intuitive. But Medtronic is getting into it, and some other vendors in Europe are working on them. So we expect that there's going to be a reduction in price. So those centers across the country who have recently purchased Da Vincis have gotten them cheaper than we got them.
MLA Costanzo, you have 15 seconds.
Thank you, and I hope with that, that is lower cost, that we should be, without question, having more, because the saving probably is 3 times the amount of money that cost, and we need to move.
Order.
Thank you.
Thank you, MLA Costanzo. It's now the NDP, MLA LeBlanc.
Yes, thank you very much. Okay, speaking of innovation, I want to talk about the website that the Conservative government promised that would track in real time the number of surgeries taking place in a day, what types of surgeries, how the numbers, how the surgeries, the wait lists have been impacted on a daily basis. And it seems like we have some of that in place now with the Action for Health. It shows the numbers of surgeries performed each day and week, but not the other information that was promised. So I'm wondering if anyone can speak to that, if that information will be added to the system or to the website, and when.
Progressive conservatives. Conservative.
Pardon me? Your mic's not on.
Dr. Tomblin Murphy.
Yes, thank you, and thank you so much for raising that, Susan, and that would be information that we would have to get back to you around the Action for Health and the dashboard, and exactly which other parameters will be shown and when, and we wouldn't be in a position to speak to that, but we will make sure that you get that information.
We can have that, yep. MLA LeBlanc.
Okay, great. Thank you very much. Also, we were talking about the e-referrals, so we're happy, of course, that that is happening. But wondering, we understood when that was first announced that the e-referral system would be a key tool to enable to see how many people are waiting for consults. So do we know how many people are waiting for surgery consults right now? Anyone?
Ms. MacGibbon?
Yeah, thank you, Susan. That's the work that's underway to be able to quantify by surgeon, by specialty, by area, by site, what those numbers look like in the most quantified way. Currently, we have lists that are maintained by surgeon or physician offices, but all of that will move to the new platform that is part of the OCEAN strategy.
I see Dr. Sinclair's hand as well.
On this, when we talk about the scope of change, and I think to a previous question on, will surgeons change or resistance? I mean, this is a huge change, right? And I'm a bit peripheral to this, but I've been in healthcare 40 years. I'm very excited about this because traditionally, family physician referred to surgeon X. The admin assistant surgeon X office kept the list. So this is a huge change. And I would say, it's being embraced. Is every surgeon and family doctor signed up? Not yet, but it's pretty close, right? So all these things, it does take, I know you don't want to say it takes time, but it really, my view is it really is on track and the right things are being done. I mean, and I don't think it's going to take that long before we start to see it. But there is a period of time to kind of get it set up, test it. But it's a huge change. Huge step. Much bigger change than robotics, frankly. It doesn't sound very exciting, but it is.
MLA LeBlanc.
Well, no. Listening, as a parent who is waiting to hear back from a pediatrician right now, I am I'm all in. But I guess that begs the question: do we have a timeline? Do we have a target of when everything would be sort of, in place and the system up and running?
Dr. Darling?
Thank you. It's an excellent question, and I don't think we have a precise answer. we can say, as Dr. Sinclair said, that I think almost all the surgeons have registered. A huge number of family doctors have registered, not all yet. The system is working. It's only been in place a little over a month. You know, there are some growing pains, so I can't answer your question directly, but I do anticipate that it won't be too long. Is that 6 months? Maybe 6 months.
MLA LeBlanc?
Well, we'll work with 6 months, and then we'll ask again. That's great, thanks. You heard it here first, folks. Also, we understand that there is a goal of incorporating like diagnostic imaging, like MRIs and CTs. Do we have a timeline for an ultrasound? Do we have a timeline for those things to be online?
Dr. Darling?
Diagnostic imaging is next in line to go onto the Ocean e-referral system. I don't know exactly when, but I would think that's actually imminent.
Okay.
MLA LeBlanc?
Great, thank you. The other, yes, I wanted to know about wait time. So it was reported recently that around 22,000 people are waiting for surgery. Wondering if we know what that number is today.
Ms. MacGibbon?
I don't have the numbers as of today, Susan, but I'm happy to provide those and follow up.
Okay, great.
MLA LeBlanc?
I might just ask one more question and then pass it on to my esteemed colleague, but I wanted to ask about the Canadian Cancer Society has called on the government to create a public plan to clear the backlog for cancer care surgery. Wondering if this is happening, if the government has a plan to do this. I know that obviously there are certain types of cancers that we've talked about today, but in general, do we have a plan or is that being worked on?
Dr. Darling?
I might just start. I think that the surgeons, if we look at wait lists and who's on the waiting list, we know that the cancer patients, yes, they're waiting, but they are being prioritized. And so the individual surgeons and surgeons' offices will prioritize their cancer patients. So specialties that deal only with cancer, for example, gynae-oncology, don't have as many patients on their waiting list, say, as the orthopedic surgeons for hips and knees, because they basically see the patient, they get booked. And so I can't speak to the government's plan, but that's what surgeons are doing because they know those patients have to be prioritized.
Dr. Sinclair?
At the IWK, of course, we do all the breast cancer surgery for the central zone, and we have been meeting those targets for breast cancer surgery for women right through the pandemic. So again, you know, the cancer surgeries really are at the top and prioritized.
MLA Burrell?
Just briefly, Dr. Tomblin Murphy, I just wanted to ask a nursing-related question. We keep bumping into the question that we have with these technological advances. There are blockages occurring because of human resources problems, and it's preventing us realizing some of the advantages of what has become technologically possible. And in our constituency offices, where we see the world not so much clinically but more through a patient's eyes and from the eyes of workers in the system, we've been contacted by quite a number of nurses, particularly around the thank you bonus, particularly those who have been excluded for various reasons, often because of their work situation having related to do with their health, sometimes off because of cancer treatment and so on. And the response that they have been receiving has, well, the case needs to be taken to the employer. So as the employer in Nova Scotia Health, is the authority, is Nova Scotia Health in a position to be able to really address these gaps in the thank you bonus and speak more to some of the difficulties about morale and a sense of being left out that has been caused about this?
Thank you.
Yeah.
Dr. Tomblin Murphy?
Thank you, and thank you for that question, and that is an incredibly important question, and I have studied health human resources planning for many years and have focused on nursing. There are a lot of things that the evidence tells us that nurses need to be valued, they need to be respected, and an incentive through monetary is one piece of that. In addition to that, there are other strategies like supporting them in ways, getting full-time positions. So we are offering full-time positions to students who are say in their second year in programs across this province, so that they feel valued, they know that they've got a career ahead of them, and we bring them in early, and that's through some of our programs that we have in place, and that seems to be working. Students are making huge contributions. For instance, we also have made nurses who are working in the organization, they need to also be incented to not working around the clock, but instead being involved in innovative things and that type of thing. The incentive around the money, that is clearly, that's a partnership across the board and with government, and I think government would be better to speak to that. But as the chief nurse, what I can say is over those 149 nurses at this point who have received that $10,000 with the 2-year.
Order. The time for the NDP second round has expired. We will move on to the PC party. I see MLA White's hand up, so MLA White.
Thank you, Chair. Just before I pass it over to my colleague, MLA Smith, I wanted to continue my question, the last one I had. I was telling you how impressed I am with robotic surgery, and I know it's about patients and it's quality of life. It's really what we're talking about here, whether that's working or just quality of life in general. It's amazing. So I got one question. Can you tell me, or can any of you guys give me a hint into how you imagine the investments in robotic surgery may have in healthcare over the next 10 years or so? Like, what's that going to do to healthcare in Nova Scotia with these investments today?
Dr. Darling?
Maybe I will start. Thank you for that. It's an excellent question. I think what the advantage of robotics that robotics brings is the ability to do precise surgery every time. Perfect surgery every time. And surgeons are just human, and sometimes we're a little off, or we do our best, but the robot is going to eliminate, maybe eliminate's a bit strong, but virtually eliminate the room for technical human error in surgery. And so it is my belief that it is going to improve surgical outcomes for all patients.
Dr. Bailey?
Just make one general comment. I completely agree. To put it simply, we're in the business of our whole mandate as heads of the department and as leaders in the hospital are to provide timely access to top quality care. How do we do that? We have the best technology, innovation, equipment at our hands, and we recruit the best people. You get those two things, they bring on more good people. And not only are we in the business of clinical care, providing clinical care, but we're a university hospital. People come here because they want to do clinical work, surgery, but they also want an environment of scholarly activity. And nobody wants to come and just be a surgeon. You wouldn't come to Halifax. You would come here to take advantage of the best things that are available anywhere else in the world, and to be around other people, other like-minded people. So the more robotics that we have, whether it's in orthopedics, neurosurgery, ENT, urology, whatever, it really creates this culture of robotic scholarly activity. And that's where I think I'm not downplaying the importance of clinical, but that whole other envelope of the importance of having a robust center of excellence in robotics it's apparent to me. I think that's what you would see in 10 years, not just the clinical, but you'd see the center of people would want to come here. People would want to come and work, and nobody would want to leave, I hope.
I saw Dr. Tomblin Murphy's hand, and then I'll get to Dr. Sinclair as well.
Yeah, just quickly, in addition to that, MLA earlier has talked a lot about efficiencies and enhancing productivity. And so if we have the right teams in place to deliver care based on their scopes of practice and working together, that's incredibly important. What robotics brings is, again, the precision, but also it brings the right care to people. So it's more than surgeons. It's bringing teams together, but it's also, our teams are broad. Back to the Dr. Janie Wilson, having biomedical engineers, having our industrial engineers who help with our flow and thinking about input, throughput, and output, incredibly important. And so at the end of the day, robotics in surgery that we've talked about today, when we look at the advancement of robotics, we also will be seeing, where we're testing and trying already, but robotics in many areas of delivery of healthcare beyond the surgery, into what's happening on the floor, what's happening in our kitchens, what's happening in our primary care in Bears Lake, what's happening in many places. So it's the way of the future, and we're in a brilliant place to be learning from the evidence.
Dr. Sinclair?
Emily White, I just want to take your question further to say, what are we looking at 10 years? Like, I've been practicing over 40 years, and this is a really exciting time, because I think what you're hearing in the surgical robotics is a move to personalized medicine, and we hear that a lot. It gets thrown around a lot, but we really are very closely there. In terms of designing, does patient X needs this type of precise surgery from robotics, and it goes beyond that. So, it may be a topic for another day. Well, we have a world-class lab here with Nova Scotia Health and IWK with some of our molecular genomics. So now we do a blood test and decides, does patient need chemotherapy X or Y? And soon, me as an emergency physician will be looking at people say, you need antibiotic X or Y based on not even taking blood from some test we can put on just from your skin. So that's, I know there's lots of hype about this, but we really are very closely there. So I think some of this innovation you're seeing, that's what's going to happen. The medicine will be transformed by this technology that's right in front of us. So that may be another topic you want to hear more about.
MLA White, are you?
I'm finished yet.
Okay.
Smith.
MLA Smith, you've got 4 minutes and 5 seconds.
I only need about a minute. I'm sure the witnesses will take up the other 3. I've said this before in committee, in that we come prepared with a list of questions, and we're ready to ask and learn as much as we can about the topic that we're dealing with. And inevitably, the questions that we have prepared, they get touched on or answered one way or another. So I don't want to be repetitive with my question. I want to make sure that we've covered everything thoroughly. So with respect to the patient outcomes, we've talked about that a lot, that recovery times are less, the incisions are less invasive, they spend less time in the hospital, so that's obviously a benefit to opening up those beds. There was something interesting that Dr. Darling said when it comes to the surgeons who are performing these, that tightening the screws, and that they can be precise with that type of procedure. So my question is about the folks operating these robots, and how have we covered everything? Is there anything else that these robots are doing to enhance the capabilities of the surgeons? Anyone who's operated one.
Dr. Darling?
Yeah, I think the robot has an incredible degree of magnification. And I think in the binder it talks about, if they're using a microscope, you're suturing with sutures that you can't even see with your eye, but because you can see them with the microscope, you can use them. And it's very similar. The robot has this incredible magnification, so you can see better. If you can see it, you can do it. The other piece of that is that the instruments that are used give you almost the same degrees of freedom as your own wrists. So the other minimally invasive surgery you're operating, people called it chopstick surgery, you're operating with these very long instruments. They only would turn certain ways. You're relatively limited in what you can accomplish compared to doing open surgery. The robot gives you all of that degree of freedom and movement that you had with your hands normally, like in open surgery, but in a minimally invasive environment. So the ability to do precise surgery is increased. There are some ergonomic benefits to the surgeon because you're seated, your arms are supported, you're not standing up, you know, shrugging your shoulders and getting a headache all the time, and Dr. Bailey can probably speak to that better than I can. So there are a lot of benefits for the surgeon as well. Some people say their surgical career may be extended because they're not going to have the aching back or the sore neck. There's advantage in terms of in the operating room, you know, your surgeon is almost completely independent. They don't need one or two assistants, for example, because they can control it all through the robot. So having an experienced assistant becomes less critical because the robot is your assistant. Your assistant doesn't get distracted or look away or, you know, cease to retract the way they used to. I mean, these are practical things, but it eliminates all of that.
Dr. Bailey?
Yeah, just to add, there's no question it's way better for the surgeon. So I've done several hundred open prostatectomies for cancer up until 2015. It was bothering my back all the time because when you do pelvic surgery, you're kind of twisted and looking down into a deep, dark hole. I stopped doing them and I had a couple back surgeries. The guys who do them now, they sit in their sock feet. Their hands are in these little gloves. They've got a pad that their head goes into, this three-dimensional camera that's high definition. The music's on, and they get up, and they're done. I mean, it's very different than this kind of thing for several hours.
That concludes the question and answer period for this afternoon's meeting. We'll now go into closing remarks, if any witness has closing remarks. Dr. Tomblin Murphy.
Thank you, and thank you so much today for the questions that have come forward, and clearly the impact on patients, on providers, as well as Nova Scotians is pretty clear. We really look forward to working with you and many people in communities to continue to advance in innovations, and in particular around robotics. So thank you so much for this opportunity today.
Thank you. Any other further comments or closing remarks? So hearing none, I'd like to thank you all for coming, and certainly, you know, you're now excused. We're going on to committee business. I'm going to take a 4-minute recess, and then I need a pee break. Yeah.
That is now.
Order. We'll call the meeting back to order. We're going to move on to committee business, and there were 2 items added to the agenda, I think yesterday. So item number 1 was correspondence from Deputy Minister Lagacé in response to the committee's April 18th request for suggestions of community partners to invite as witnesses at the meeting on implementation of additional mental health and addiction supports, in addition to the Office of Addictions and Mental Health. So Deputy Lagacé has suggested Star Cunningham, CEO of the Mental Health Foundation, and Karen Nichols, Executive Director of the Canadian Mental Health Association. So I'm looking for discussion. MLA Smith?
I have a motion to put forward to support those recommendations if the chair would like to accept it now.
Yep, so there is a motion on the floor for...
I can read it formally if you'd like, sir.
Yeah, that would be appropriate.
I move to add Star Cunningham, President and CEO of the Mental Health Foundation of Nova Scotia, and Karen Nichols, Executive Director of the Canadian Mental Health Association, to the PC topic of implementation of additional mental health and addiction supports.
So we have a motion on the floor. Any discussion on the motion? Seeing none. All those in favor signify by saying aye. Aye. All opposed, nay. Perfect. Motion is carried.
For the record, can you just correct that? Both of these correspondences.
Oh, yes. And I do apologize. I skipped over because I saw March, but it was in committee business. It says March 4th and March 5th, but it's actually May. For the record, it's May 4th and May 5th that those emails came in. Item number 2, correspondence from May 5th, email from Deputy Minister on Health and Wellness. This was volunteered suggestions for witnesses on some of the topics. Again, this was forwarded to members yesterday. Is there any discussion on this? And I will note that these suggestions were unsolicited, so this was not something that the committee had requested. We'd already kind of went through our witnesses with our committee when we had our actual committee agenda setting. But if there is discussion, I'm open for discussion. MLA Di Costanzo?
For us, when we put a topic, we ask for our witnesses, so we don't need assistance or telling us who we should bring. So we're fine with whatever we've given. But if the government who had put a topic and they wanted to add, and that was their choice, there's no problem. We were okay with that.
I see MLA LeBlanc's hand up as well.
Yeah, I just wanted to confirm. So in Deputy Lagacé's email, I believe it was for the EHS offload times. Is that because I remember reading it, and she had suggested the paramedics union, the people like Mike or Jeff and Kevin, I think, Kevin McMillan and someone else from the paramedics union. Anyway, my point is that because that's a Liberal topic, so I just want to get clarification that the Liberals, like... I
believe they're already on that one.
Well, yeah,
like
that's right. That's what I'm saying. Like,
I will be honest, like, I think this was, unnecessary. Like, I think it came, we already kind of have our witnesses. Everybody's had their witnesses. We approved them at our last meeting. This was for information. It was delivered, so we wanted to make sure the committee got it. I don't know if we
so we're
have
good,
any.
right?
I think we're good. I just wanted to bring it to everybody's attention because it was sent to the clerk so that everybody saw it. So if we're okay with that, MLA McGuire?
Just for our topics, Liberal topics, we just want to keep the witnesses that we had approved. It's great that the deputy had volunteered witnesses, but we're going to stick with the ones that we had already approved.
I think that's appropriate.
Thank you. I'm not wearing a jacket.
So any further discussion on that item? Seeing none, is there any other business? So hearing none, our next meeting is scheduled for Thursday, June 15th, 2023 from 1 to 3. Mental health supports for First Nations communities. Witnesses include Tajik Gimmick, Mi'kmaq Health and Wellness, Mi'kmaq Nova Scotia Health Directors Committee, Nova Scotia Health, IWK Health, Office of Addictions and Mental Health. So with that, the meeting is adjourned. Yeah, it was a bit of a